Welcome, everyone, to today's webinar, Medicare, Medicaid, What to Expect in the Biden Administration. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're going to do our best to get through as many of these as we can, so this will be a sort of rapid-fire Q&A. We'll have a series of poll questions during today's webinar. You can submit the answer that best applies to you directly in your screen in the slides box. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to introduce our speakers, Paul Keckley, Managing Editor, The Keckley Report, Mitch Morris, MD, CEO, Optum Advisory Services, Eric Larson, President, Advisory Board Company. Paul, Mitch, and Eric, thank you for being here today. Mitch, I'll turn it over to you to get things going.
Fantastic, and thanks, and welcome everyone. Thanks for taking your time out of your day to join us for what I think will be a very interesting conversation. You'll probably be glad to know we don't have a lot of slides. This is really meant to be a discussion of some of the changes we expect to have happen in our health ecosystem in this country during a Biden administration. When we first planned this conference, I'll be honest, we didn't necessarily expect the control of the Congress to also shift, even though it's the narrowest of majorities. We did expect COVID to still be a significant problem, and it is, as well as an ongoing economic recession. So trying to divine, dusting off our crystal ball, is healthcare in for an inflection point, which happens every once in a while, or is it going to be more of an evolutionary process or perhaps even gridlock? And I think we need to be ready for any of those eventualities. And I've got two outstanding panelists today that we're going to have a conversation with. We're going to talk about what's likely in Medicare, Medicaid, also commercial programs, public health funding. We might touch on virtual and home care. But there's really two key questions here. In the Biden administration, what's likely to be the top initiatives and what's likely to get done? And the other question is, what are some of the implications for the different aspects of the private sector? And I've got two fantastic colleagues and friends of mine to join us in that discussion today. And we're also looking forward to your questions as well. Let me first introduce Dr. Paul Keckley. Paul is an outstanding speaker. He's been a prolific author for many years. He's been privileged to advise a number of administrations on health policy, including some of the key parts of bringing the White House and the private sector together for discussions during the formation of the ACA. We worked together when he was the leader of the Deloitte Center for Health Solutions. He publishes the Keckley Report every Monday morning. It's free of charge and an outstanding read. If you're not familiar with it, I recommend it highly. But his insights into policy and some of the likely implications I have always found tremendously valuable. Our other panelist is Eric Larson. And as mentioned, Eric is president of the advisory board. He's also a really eminent thought leader. He's a leading expert on some of the market forces that we have today in healthcare, on industry transformation. One of the things that Eric puts out that I would also recommend is Lessons from the C-Suite, which has 250,000 subscribers. It's one-on-one conversations with some of the most influential executives in healthcare, venture capitalists, private equity, life sciences, government. So I always learn a lot when I listen to those conferences as well. I'm sure you will if you want to join into them. So let's start off, Paul, with you and talk a little bit about some of the potential scenarios that we'll see under a Biden administration. And I'm interested in what you think is going to drive some of the decision making. Is it some of the monetary pressures in a recession? I think we're going to see, rising enrollment in government programs, both with the aging boomer expansion into Medicare, and then potentially expansion of Medicaid as well. and then there's a longer-term impact of COVID-19. So I know that's a lot on there, but why don't you just start off with some of your perspectives on direction?
Thanks, Mitch, and I look forward to also hearing from Eric. I think there are three overarching themes that have really front and center position in the Biden administration's view of its health policies over the next 2 to 4 years. One would obviously be the pandemic and the extent to which they can successfully achieve an objective of herd immunity by June. That would be a stretch, as many have conceded, simply because our logistics and distribution processes have not reached optimal levels, and that's even assuming at least 2 to perhaps as many as 4 other vaccines getting emergency use authorization. So that's one, and that's the obvious, and that seems to be the focus of its attention right now. But the two others that are, I think, equally important are, one, the looming federal debt. We sit right now at $27.8 trillion in federal debt, and that's before the current stimulus package is negotiated in this Congress. And the likelihood that a Bernie Sanders, who's stepping into the Senate chair seat, might use reconciliation to get a stimulus package through. But the debt is huge. At 127% of the GDP today, that means that we would not climb out of that debt by simply growing the GDP. It means that the federal government has to collect more revenues through changes in the tax code. And it also means that to some extent there'd be some cuts in appropriations. I think at the top of the list would be military appropriations, which, as you know, are over $730 billion of our federal budget. And of course, healthcare, Medicare, Medicaid, and the other obligations, which constitute about 1/3 of the spend of the U.S. government's appropriations. So that's second. That's the deficit and how you deal with that huge overhang. And I think third and obvious is election politics. Folks forget that when you've had a Congress that was controlled by one party, Bill Clinton came into office with both houses democratically controlled. Barack Obama had that as well in 2008. Both lost the House in their first midterm. 54 seats lost with Clinton, 63 seats lost with Obama. So everything in the Biden administration's foresight is very conscious of the fact that in 2 years there's a midterm, and much of its agenda will be shaped not just by its aspiration right now, but by what the Constitution of Congress will be from 22 to 24. So those three things are kind of the big overhang.
Yeah, thanks. You know, you mentioned the reconciliation process, and I'm not sure that's something that everyone's really aware of, some of the subtleties between reconciliation and more direct. Do we need bipartisan support to make progress? A, and B, is that likely? And I guess if it's not likely, then all you're left with is reconciliation or executive orders. Is that the case?
Well, executive orders probably not relevant to the question of some of the big changes that would come from a Biden health administration. Reconciliation essentially says with a vote of 51 in the Senate, you can pass legislation that otherwise would have required 60 votes, and it has to be tied directly to a budget item. And in many cases, the Senate has resorted to that, both parties, getting back with Bush 43 and forward. So the betting odds are that it will the stimulus package of some sort will require a reconciliation vote. It will not get 60. And that sets in motion the tone for the administration for the balance of its first 2 years. The other thing to remember, Mitch, is who the chairs of the committees will be. In a 50-50 Senate, with the current power sharing arrangement that Chuck Schumer and Mitch McConnell have brokered, that really will require that the chairmanships be split between the parties, that the memberships on the key committees will be split in half with the parties. So there's going to be an interesting dynamic playing out in the Senate, but not to be forgotten, the Democrats lost a dozen seats in the significant majority they enjoyed in the House pre-election. So Nancy Pelosi has to be cautious about how they advance legislation, and all of this at the time when over the next 3 weeks we're going to hear a lot about the Senate impeachment trial. So I don't believe a lot of the big, hairy, audacious goals that were set in the Biden administration's policy platform will be achieved in the near term, simply because of this impasse in the houses of Congress, the overhang of the impeachment, and the question of just exactly how we're going to get monies in the hands of people most in need.
Yeah. No, I think that's insightful, Paul. Let's concentrate a little bit on Medicare programs.
Yeah.
There was a lot of talk during the election cycle about lowering the age of Medicare. Certainly, there was talk about Medicare for all as a possibility. What do you think the likelihood is of changing eligibility even a little bit for Medicare going forward?
Low, simply because that would also encumber more federal funds to this program, which, as we said earlier, this budget overhang is a huge challenge. So if we were to expand eligibility, currently we enroll about 10,000 more per day in that program. If we expand that eligibility to 60, even if we do that incrementally, we do this over a period of 5 to 7 years, it still adds to the federal spend in Medicare. And the levers in the Affordable Care Act, and it's also ironic, we've not heard a lot about the Affordable Care Act since the election, but the levers for reducing cost in the Affordable Care Act were really two big items. One was, let's shift all the incentives from volume to value. There were 7 different types of volume to value changes in the Affordable Care Act. And the second, which people have forgotten, was the Independent Payment Advisory Board, IPAB, which was an entity set up to step in if the government overspent money in Medicare. Well, the IPAB was thrown out, one of the many changes to the ACA since it was passed. And the value-based purchasing models have proven not to produce the savings that Medicare expected. Of the 54 specific alternative payment models that have been implemented since 2013, according to CMMI in its latest report just released last month, they found only 5 had actually saved money. Now, it's not fair to assume that that's simply because they were bad ideas. The benchmarking process, whereby you set a savings target and rewarded providers, moved around almost by the nanosecond. It made it very hard to calibrate the effectiveness of the program if every year you had to change attribution, benchmarking, and so on. And second, what we found is providers, unless they have very little risk and can enjoy a fairly predictable savings or a bonus, they're just not going to participate. So you kind of step back and say, what models might be effective in reducing the Medicare spend that would also be attractive to providers? And that's kind of a head scratcher. And if history serves us, the ones most likely to be able to participate in those are those that are very experienced in managed care, those that had a lot of expertise in capitated payments, care coordination, had good clinical data support, and so on. So that requires capital, it requires physician leadership, and it certainly runs afoul of the way a lot of providers think healthcare should be, which is kind of leave me alone. Let's practice the way we always have. But if you want to put a morsel out here, a savings program, and I can be sure I can get a piece of that, I'll do it. But I don't want too much disruption of the way I've always operated. So I don't think in the Biden administration's view of Medicare, at least in the next 2 to 4 years, the levers they'll be able to use go much beyond, one, adding a few value-based programs with some significant savings to Medicare that may require mandatory participation. That's going to be a very contested discussion. Two would be just conventional reimbursement cuts, which we've seen now. That's been the mode of operating for Medicare now for almost 30 years, since the mid-'80s. Just every year, change the reimbursement formula, tweak it a certain way. But I think a third that will be timely and topical is the role Medicare Advantage plays. Medicare Advantage has proven to be a pretty substantial engine for Medicare savings. It has some headwind that I think will get attention from the administration. It appears that Medicare Advantage enrollees are a bit healthier than fee-for-service Medicare enrollees. Medicare Advantage did not attract the higher income cohort of Medicare enrollees because a lot of those folks could just simply buy a supplemental policy and have first dollar coverage and pretty much no constraint on what they do. And Medicare Advantage has, in regard to its enrollment growth, now at about a third of the Medicare population, has actually spent more than that growing rate of its enrollment. So I think there will be some constraints put on Medicare Advantage, but there will not be a method or an approach that says we need to discourage Medicare Advantage. I think it will be encouraged, but it will be constricted somewhat by the amount of funding that the feds are able to put in that program.
Yeah, no, that's an interesting perspective. And from the Optum point of view, we have certainly pushed Medicare Advantage, the role of primary care, and the ability to manage risk is an important part of our strategy, as have many other health providers. But this is a good point to turn to you, Eric, and talk a little bit about your perspective on how health providers are accepting the move to value-based care. And you and I often debate this because there's a professed interest in moving from volume to value, but the cost structure and the economics of fee-for-service make it a very powerful anchor. What's your perspective on what might happen over the next few years? And a corollary question, some have wondered, well, maybe the pandemic is going to push more organizations in that direction. Is that true or not?
Yeah, Mitch, it's a well-articulated question, and I very much appreciated Paul's perspective on this. The CMMI retrospective that Paul is referencing, there's actually a really fascinating New England Journal of Medicine editorial last week by Brad Smith, who headed CMMI. And it was very reflective about, look, we've invested $20 billion over the last decade. And of these 54 programs, very few of them have demonstrably moved the needle. And so the sort of foundational premise that Paul is introducing, I think, is a really, really sound one. And it begs the question, what is the private sector going to do to sort of catalyze this long-awaited move from volume to value? And if you look at the pandemic, it's really interesting to see a bifurcation of who did reasonably well and who really struggled. And the group that predominantly did well are the vertically integrated payer providers. These are the Kaisers, the Intermountain, Sentara, Presbyterian, et cetera. Those that had some inoculation against the wreckage that happened to fee-for-service reimbursements and the disappearance of the volumes. And you saw over the months as the pandemic dragged on that those vertically integrated players had less exposure to the damages of a predominantly fee-for-service system. And so it begs the question, how quickly will the pandemic potentially accelerate the move to risk, or will it potentially be a decelerant in some ways? And, I want to kind of demystify things just a little bit, because we often use really casual, loose language to talk about value-based care. And I really want to bring some precision to it. So less about shared savings and more about capitation, true delegated downside risk. And it's a big misconception, because for all the rhetoric in the industry, the reality is that health systems, by and large, have a very de minimis share of their revenues in the form of full capitation. In fact, by our calculations at the advisory board, up through 2019, the average health system had a 1.6% of their total revenues capitated. And that presents an enormous challenge, because the academic literature would suggest you need 23 to 29% full capitation to practice true non-schizophrenic population-based medicine. And you can look at those ambulatory sensitive admissions and divert them. You can, when you're below 1/3 of your revenues, you essentially cannibalize your fee-for-service revenues by reducing their volumes. Above 30%, you can make the economics go around the block. And the challenge is the distance between 1.6% and 23 to 29% is a really formidable one, especially given the frailty of hospital and health system margins. I mean, the AHA, as we know, is projecting a $320 billion revenue loss this year. And so the question is, given the fragility of the economics, how quickly are folks going to be able to move toward building the infrastructure, accelerating the construction, and actually taking delegated risk? And I'm a little concerned about that, Mitch and Paul. I'm not blindly optimistic that that's going to happen. I'm hopeful, and we are seeing some accretive partnerships between payers and providers. And, forgive the monologue, I want to add one more point, Mitch, and then we'll pause. There's a logical question, should providers become health plans? And there was a lot of energy around this in the early part of the 2010s and the mid part of the sort of 2015 to 2017 range. In fact, between 2015 and 2017, there were 37 new provider-sponsored health plans launched, and 4 existing health plans acquired by providers. But at the end of 2017, the returns were pretty discouraging. In fact, you only had 4 of those health plans that had either 50,000 commercial lives or 5,000 MA lives. And then the period 2017 to 2021 has also been a little discouraging. The numbers just came out. So if you look at the new emerging MA plans, there's only been a handful of provider-sponsored ones. And the incremental volumes that they've attracted have been a little bit deflating, 1,000 here, 2,000 there, et cetera. And so I think we're going to have to move toward risk. And as we go into the dialogue, Mitch, I want to offer where I think risk is going to really materialize, and it's going to be on the ambulatory side, on risk-bearing primary care groups.
Yep, we're gonna come back to that, because I know you have some particular perspectives on also how that gets funded and invested in. But Paul, let me come back to you and talk a little bit about Medicaid. So even during the Trump administration, some states that had not participated in Medicaid expansion decided, well, maybe we will. And there was talk about getting a little bit more creative about how we manage some of those lives, including behavioral health, social determinants of health, and looking more holistically at that population and trying to help them as opposed to what's traditionally in that bucket. What do you forecast in a Biden administration would be an approach to Medicaid funding, expansion, and also some innovation?
Well, the easy answer is the elimination of work requirements and the cessation of block grants to states for Medicaid is a start. That's simply religion within the ranks of the Biden administration, and you're certainly starting to see that play out already. Then what do you do about coverage and funding? 39 states at this point have expanded their Medicaid programs, and it turns out that those states where that's occurred, the cost increases have been lower than in states where they weren't. Second, in 37 states, Medicaid is in part or full outsourced to Medicaid managed care organizations. We've all read about Centene and a variety of others who basically embrace somewhat a model of managed care that says preventive and primary care, extension of services beyond traditional allopathic incident-based or episode-based interaction is not the way to go. So I think the administration's view of this will be, and remember, we've got 27 Republican governors. We have 23 Democratic governors, but 66 of the 99 state legislative bodies are controlled by Republicans. So it's an interesting sell to say we have to really expand the Medicaid program, and we promise we can save money. So in the next 2 years, expansion will be in certain targeted populations and in certain states, and some grace period so that these other 11 states that did not expand their Medicaid program will have an opportunity to expand it with some federal subsidies. And I think you'll see this concept of the health marketplaces and the public option begin to blend, where the federal government steps in and helps states that allow many people above 133% of the federal poverty level. That's where most Medicaid states eligibility stops, to participate in this program while expanding somewhat the Medicaid program. I don't believe anything is more opportunistic for the private sector than managed Medicaid. But it's to what Eric said, that's not the delivery system that's focused on the bricks and sticks in the hospital. That's a series of ambulatory and public health services that have proven to be the undoing during the pandemic. So I've looked at every state's plan for its Medicaid program in its next year fiscal budget, and each one has basically said we can afford no more from state coffers to fund the Medicaid program. Remember, states have to balance their books. The federal government can deficit spend. So what this says is the federal government will be writing bigger checks to states to allow them to expand somewhat the eligibility and enrollment in their Medicaid programs, and will put more constraints on how those states may choose to outsource their Medicaid program to private managed care organizations. And I think the sum of those together is expanding Medicaid will be north of 80 million in all likelihood within 2 years, and a program that's centered around ambulatory, preventive, public health, and primary care that becomes kind of a hybrid model, kind of the front door to a gatekeeping system.
Yeah. Well, that's fascinating. And Eric, I'm going to follow up with you on how the private sector might react to that, because what I'm hearing, Paul, is that the onus is on the private sector, including all the nonprofits that are part of that, to really come up with some creative ways of focusing on total cost of care and all the aspects of the quadruple aim. But if we can't make the economics work, it's hard to get the other three pillars to work as well. Last question before I want to turn more to the private sector, but pharmacy costs. We've got transparency rules. We've got some initiatives that started in the prior administration. What's your prediction quickly on how the Biden administration might begin to address that?
It's notable that drug spending slowed a little bit last year, but it continues to be problematic at both level 1, the generics, and level 4, the specialty pharma, in the formularies. So I don't see the Biden administration taking on the prescription drug industry head on. It actually has pulled back from some earlier orders that the Trump administration had brought forth. Is there going to be pressure on the managed care organizations, on Medicare Advantage and in Medicaid managed care, to have tight formularies? And will there be some enabling of their ability to be very restrictive in their formulary design and in their medication management programs? Yes. And the Biden administration, as you know, said we want the federal government to be able to negotiate with the drug companies directly, taking the middleman out. And it's kind of an unfair but true hit on the prescription drug industry. About 40% of the cost escalation for prescription drugs is not at the manufacturer level. It's at the distribution and the retail and the layers between manufacturing the drug and it ending up in somebody's medicine cabinet. So the industry will be under more scrutiny. The pressure points are probably going to be driven through these managed care organizations and tighter formularies, and these provisions that certain drugs will have more pressure than others. I suspect we'll see that play out, but not in the next 2 years.
Yeah. Well, that's an interesting perspective. And one of the things with all of the different choices of just merely passing a randomized clinical trial showing relative efficacy, we don't really use real world evidence all that much to make decisions. And we're starting to see the industry do that. And hopefully with greater access to data and some of the things that come from these transparency and data sharing rules, we'll have a better handle on the real world evidence so that we understand when is it worth paying a premium for a new medication. So I'm something.
Let me add one thing that it's really interesting, because if you think about the role the managed care organizations in Medicaid and managed care play, they're all introducing non-allopathic interventions, some around social determinants, some over-the-counter therapies that are evidence-based and effective. So I think the strategy that would be the least difficult to implement in the near term will be to put pressure on the MCOs to take a more proactive stance about drug cost and give more latitude as they restrict their formularies and substitute some non-traditional therapies in their medical management, than to go broadside against the pharmaceutical industry, which, as you know, in the U.S., it's really 36 companies. 36 companies really control the prescription drug industry in the U.S., and they're not going to give up the U.S. market. The U.S. market is a third of global revenues to the prescription drug industry, but it's almost 60% of the profits to the industry. So they're not going to run away from the U.S. market.
Right.
Yeah. Say, Eric, one of the things I wanted to ask you about, switching gears a little bit, is we've seen ongoing industry consolidation, lots of M&A activity in the last few years. Though a lot of those deals require regulatory approval. How do you see M&A changing at all, or if at all, under a Biden administration?
Yeah, Mitch, it's a really interesting question to think about because, pre-pandemic, under the Trump administration, under the Obama administration, there was sort of hyperactivity in the merger and acquisition space. And we can delineate what's going on in the hospital and health system sector with what's happening across other parts of the ecosystem, especially the ambulatory side. And I want to kind of draw a line between the two. And it's important to note how hyper-consolidated we were coming into the pandemic. And so, again, we know the math. This is a $1.3 trillion sector, 6% of the GDP, 6,000 hospitals. But it was remarkably consolidated. In fact, pre-pandemic, the top 100 health systems, so the top 92 not-for-profits and the 8 largest private equity-backed and publicly traded hospital companies, those top 100 controlled $856 billion in revenue, 65% of that $1.3 trillion total. And the top 10 controlled $324 billion out of that total. So already massive consolidation. And, you did see a deceleration during the pandemic, but not nearly as much, Paul and Mitch, as one would have predicted. In fact, last year there were 79 announced mergers versus 90 in 2019. And what's different about that is you had a lot of mega mergers announced. So those with a denominator greater than $1 billion, and you had 7 of them announced last year versus 3 the previous year. So it's a really good and timely question to ask, what is the Biden administration's posture toward horizontal M&A going to look like? You had a little period of dormancy there for a few years by the FTC and the DOJ with regard to horizontal hospital consolidation between 2016 and 2019. Really not a lot of not a lot of opposition. And then you had the Jefferson-Einstein merger opposed last year, which was the first time in about 3 years. That's still under discussion, and judges interceded, and it may go forward, so we'll see. One of the big trends, Mitch and Paul, that I'm going to be watching is what's going to happen with non-contiguous mergers. So these non-adjacent, multi-state, mergers. So Advocate Aurora was obviously a really important one. There were a couple announced last year that, for pretty unique idiosyncratic reasons, didn't go through. So Stanford and Intermountain and Advocate Aurora Beaumont, really outstanding systems, but for unique reasons did not go through. And so, I believe we are going to see an acceleration of hospital M&A. It's just hard to separate out the economic fragility of a lot of these players from coming together and consolidating back offices and really becoming operating companies from holding companies. And the last thing I'll say on the horizontal M&A side is the pandemic. I mean, there's a lot of darkness, but one of the bright spots was seeing some of the systems really coalesce and exercise the value of being a system. In fact, the advisory board's been publishing on this for years. And we were, I think, collectively as an industry, really watching for when is the moment for systemness. We actually saw it frequently enough that we didn't see real synergies from a system that we labeled it SINO, S-I-N-O, systems in name only. I think the last few months have really reversed that narrative. And it was deeply encouraging to see systems coalesce, figure out how to get PPE, figure out how to, build tent hospitals where they needed, convert ICU beds, really synergize as a system. And I think that's a good sort of harbinger of a value of systemness that we may see across 2021. It's going to be interesting with Xavier Becerra. He was a very vigorous opponent to horizontal integration in California, and it's a signal of where the administration may be going, and a disinclination to support intrastate mergers, and we'll see how it plays out in interstate mergers.
Well, they've already
announced a little bit on the
announced.
ambulatory side, but yeah, Paul.
Can I just mention one thing? I mean, you're just spot on. The FTC has already kind of sent notice that it's going to be paying close attention to the in-market competition and consolidation. And I suspect where consolidation has been justified by reduced savings and benefit to the community or the consumer, there may be some revisiting of those deals, not undoing the deals, but perhaps make goods or some penalties. And they're also looking closely at private equity physician consolidation in a same kind of very suspect point of view, that perhaps this is more about gaming the system and private equity making bank on some consolidation than it is benefit to community. So I think it's a theme to watch.
Yeah, no, that's an excellent point. I think that leads to the next question, and I think you're going there already, Eric, is on the ambulatory side, there's a lot of activity with private equity, with health systems, with health plans, the so-called rise of the so-called payviders. What's your take on where that's going in the next few years?
Yeah, I want to build off, Mitch, what you're saying and what Paul's saying, because private equity has been a very energetic force in healthcare. And I think it's going to become much more consequential as we go forward. And it might be worthy to take a step back and just talk a little bit about private equity as a sector. And, you know, it's a Goliath. There is right now $1.5 trillion in uncalled capital, or dry powder, that private equity is looking to deploy across the globe. In healthcare, they've been very energetic. So the last 3 years, we've averaged about $80 billion invested in healthcare annually. And 2020, in the teeth of the pandemic, did not decelerate private equity's investments. Now, the composition of their investments has shifted. And private equity is not monolithic. There are a lot of different kind of colors and species and folks that are going after different niches in the market. You've got private equity groups investing in hospital companies over the last few years. So Apollo with RCCH and LifePoint, Equity Group International, EGI investing in Ardent. You've got a lot of biopharma investment by private equity. You've got, as Paul mentioned, potentially the most consequential set of investments by private equity is in the ambulatory space. Now, private equity's thesis about where they're investing in healthcare has shifted. And it's going to be really interesting to watch how the Biden administration and a Democrat-controlled Congress is going to respond and regulate private equity. And there's a lot of speculation about that. But private equity on the ambulatory side, its thesis has shifted. A few years ago, it used to be about platform plays, buying dermatology, ophthalmology, women's health, orthopedics, et cetera, subscale, aggregating up, professionalizing the back office, buying at a 4 to 8 multiple of EBITDA and selling at an 8 to 12 multiple when you actually extract those back office synergies. In the middle of the pandemic, you started to see private equity's focus shift. And instead of those predominantly fee-for-service plays, they are now capitalizing risk-bearing primary care groups. And this is very significant in my estimation. And you had some public, IPOs that were very celebrated. You know, One Medical with about a $5 billion valuation, Oak Street, which as of today has a $13 billion valuation. And in the last quarter, in Q4 2020, there was $2 billion invested in aggregating up physician practices. 75% of that was done by private equity. And I want to give you just one quick story that I think is illustrative of the valuations going sky high. And you have to ask, what are the consequences for hospitals and health systems and for larger ambulatory groups? I mean, this has been a brutal year for our heroic frontline caregivers, and primary care has not been exempted. There are 220,000 primary care doctors in the country. Over 50% of them were employed by hospitals or health systems as of 2018, so the number's higher now. Those 220,000 primary care doctors across the pandemic, Mitch and Paul, collectively lost $15 billion in revenue. 25% of those primary care doctors are over the age of 65. So you're going to see a wave of retirement. And now you've got some asymmetric investors like private equity and publicly traded entities like SPACs, special purpose acquisition companies. We need to talk a little bit about that. And so the one story I quickly want to tell you is about a great medical group called Cano Health. Cano Health is one of these so-called extensivist clinics managing the polychronics, the sickest of the sick Medicare Advantage players like ChenMed or Alignment or CareMore. They were invested in by private equity just a couple of years ago. In 2017, they had just a few clinics and had a $30 million investment. Fast forward 3 years later to August 2020. Now it's a big company, $1.45 billion in revenue, an $83 million EBITDA, so they're profitable, 70-some clinics, if my memory's correct. They were going to look to do a transaction. And so they went to the market and they said, we're going to look to sell this entity at about a $2 billion valuation. Private equity companies looked at it and said, I think we're going to value it at about $1 billion. And normally you'd have a negotiation and end in the middle. Well, for those of you that haven't been following the SPAC phenomenon, the special purpose acquisition companies, which are kind of blank check companies that do reverse mergers, they've been around for a long time, but they kind of went stratospheric in 2020. In fact, there were about 220 of them that went public in 2020 that created $85 billion in IPO proceeds. You've got to do an acquisition. It's a blank check company. You've got to buy something within 2 years. Well, a blank check company came and looked at Cano. And on November 12th, did a transaction that valued it not at $1 billion, not at $2 billion, but valued it at $4.4 billion. And my point, Paul and Mitch, is that this is a new asymmetric investor that's going to change the composition. What is primary care going to look like when you've got this kind of valuations going? And Paul, you talked about the $27 trillion deficit. We've got a super expansionary monetary policy, fiscal policy. You've got liquidity flooding the market. This is affecting ambulatory valuation. So let me pause there and just get reaction. Paul, I'd be curious if you're seeing it differently on the ambulatory side.
Not at all, although I'm reminded that not every PE fund operates on the same thesis. Some are under the conventional model of buy the assets, hold it for 5 to 7 years, get a 20% CAGR and a 2% management fee and flip it. And those folks are still prominent in the market, mostly in a lot of that single specialty space. But you're talking about a new breed of private equity that has valuations that are typically not sustainable, but that attract a huge amount of contractual obligation on the part of the doctors, who in many cases are really not sure what they're getting into. So we're going to have some seller's remorse. We're going to have a lot of messiness in the market as this thing plays out. But I think your assessment's spot on.
Yeah, I want to make sure we leave time for questions. This has been a great conversation. I want to end up the formal part of the questioning with talking a little bit about investment in and the regulatory permissiveness of home care virtual telehealth. And, if you think of the other silver linings of the pandemic, it's been the acceptance of telehealth as a reasonable and high quality modality for delivering lots of different kinds of healthcare, including behavioral health. First to Paul, what do you think the future holds for that in terms of it being, is the train left the station, or are they going to try to bring it back?
Well, the train left the station, but the sustainable business model is still a holy grail that many have not achieved. I think it has to be integrated within payvider, vertically integrated health systems of scale to have its ROI be impactful. And at the end of the day, it has to show a net reduction of cost versus any other mode of delivering health services. And I think we're still seeing that early waft of a lot of activity and a lot of promise and some very interesting PowerPoints, but we have to see the substance of the result.
I love that.
No, well said. Eric, what's your take?
Yeah, so I agree with Paul. I might be slightly more optimistic. And we might be converging around the same idea. I'm a huge proponent of home as an epicenter, hospital at home dialysis, home remote patient monitoring, home infusion, home SNF potentially. I think we're going to see a real compressed evolution here on the home care front. And it's been really encouraging to see the regulatory framework, which has always been understandably slower moving, start to catch up. Hospital at home is a great example. If you could take 180 predominantly medical DRGs and with clinical equivalency, if not superiority, and demonstrable cost reductions and do it in the home, I think that just makes a ton of sense. And if you think about what are the pandemic structural shifts that are going to endure, once we see the back of this thing, and may that be soon. I mean, we can agree that site of care shift is going to be one of those really big secular trends. Top of licensed practice, and home as an epicenter, and they're all converging around patient preferences. Patients want to age in place. I mean, 2019 was the first year in history that we had fewer patients die outside of the hospital than within. And we still had 700,000 folks perish within facilities. Folks want to age in place. They want to be at home. And you've got this fascinating convergence of the technology enablement. I think RPM has now evolved to the point where it can actually support a lot of these evolving clinical pathways and protocols, et cetera, and a regulatory environment that at least over the last year was supportive. I don't see the Biden administration reversing some of these regulatory amendments and expansions and clarifications. And the capital markets love this. The capital flowing to,
Eric,
yeah.
I want to leave time for questions, but I think you're suggesting the next topic in our series should be the digital front door and the home as the epicenter and the true meaning of patient centricity, because that's what all this involves. And we could easily take an entire hour. But let's stop the discussion and see what questions we might have from the audience.
Yeah, absolutely. We've got so many great questions that have come in, which just speaks to the caliber of our experts here and the importance of this topic. So we're going to dive right in, and I'm going to just read these off rapid fire and have our panelists here knock them down as they can. So first question I'm going to throw out
and we'll
to
do
you.
rapid fire answers.
Okay, great. What impact COVID, administration change, economy, what impact did these factors have? Do you anticipate them having in non-acute services such as outpatient care and long-term care?
Paul, you want to take that?
Well, it's obvious. It's substantial growth with lower margins.
Great,
Yeah.
great rapid-fire answer there.
I might differentiate between institutional post-acute and non-institutional post-acute. And I think apropos of our home as an epicenter, kind of back and forth, I think you're going to see a lot of acceleration to what of those services can be safely and economically migrated to the home. As Mitch said, maybe for our next conversation, we can address that.
But I think we ought to go at that same discussion around this continuum and SNF and long-term acute and rehab, where there's so much opportunity for efficiency, but has not been scaled, nor has reimbursement allowed adequate innovation. So I think that's where that gets integrated into a platform play offered potentially by a big vertically integrated payvider system, or a real disruptor who says, I need all those pieces. I don't necessarily need a hospital at the center.
Thanks
Next
for that,
question.
gentlemen. I'm going to go ahead and jump to the next question. So how will the Biden administration re-engineer healthcare for value and not just make expensive affordable with taxpayer handouts?
Well, I think we touched on that a little bit already. Paul?
I just don't think that there's a clear, true north as to that answer in that administration right now. I've listened and studied their policy discussions, and I don't think we've got clarity about that right now. I do think that they are betting that managed health, which is code, as Eric alluded to, some model of capitation, is the route to that end.
Gotcha. Well, appreciate you revisiting some of this stuff. The next question, I'm just going to throw it out there. What is the Biden administration doing for healthcare information interoperability?
Well, they've named the new ONC team, and I think it's notable that funding for interoperability and meaningful use has sustained 2 political parties and 3 administrations and remains somewhat intact. So I think they expect that full implementation of interoperability, though delayed as a result of the pandemic, probably another 2 or 3 years.
Agreed.
Great. So next question then is, what about models that are out there as value-based agreements to save money with Medicare Advantage? Bright Health, Oscar, any additional comments you can make around programs like that?
Yeah, I think those are a vibrant new part of the ecosystem. They're digital forward. I think that they are capitalizing on folks' increasing comfort with synchronous and asynchronous communication and kind of that digital front door. And, you know, the volumes they've attracted, the enrollees they've attracted are still comparatively very small. In fact, I just saw the numbers for these. Bright, Devoted, Oscar, you aggregate them all up, it's still less than 1% of the total of Medicare Advantage. There's a lot of prospective room to grow. And the last thing I'll say is you are starting to see some of the real established incumbents, including United, Humana, and others, really embrace this digital first platform. So as always, disruptive innovators tend to encourage the incumbents to evolve as well. So I'm pretty bullish on this space.
Next question, what do you anticipate as far as LTC Medicaid funding, oversight, impact of the baby boom, COVID, other factors?
Paul, you want to comment on that?
Well, you're talking relative to reimbursement or regulatory oversight?
I believe oversight is what they're in reimbursement. If you want to touch on both quickly, I think.
Well, there's recognition that there's substantial fraud in much of the post-acute space, SNF and otherwise. So I think you'll see OIG and others become activists in these sectors. But they're also looking at managed Medicare as a major thrust toward integrating this more directly into a seamless system of health, in which, as Eric has referenced, the home plays a bigger part. We know that the fraudulent claims relative to total claims in the SNF space proportionately higher than any other sector. So I think that's on the radar. It's notable, by the way, just of the 143 pardons and things that the Trump people got through the past week, 18 of those involve fraud in healthcare. So let's just be aware there's a lot of attention being paid to fraud in the system.
Well, thank you for shedding light there. We are approaching time, so this will likely be the last question. The attendee asked, several rural hospitals are closing. So what is your prediction for this sector? What is your prediction for rural hospital health moving forward?
You know, rural is an area where at Optum we have a great interest in understanding. It gets to some of the things we were talking about, is the digital front door, telehealth, virtual. How do you begin to deal in a holistic way, not only with medical problems, but behavioral health and understanding the social determinants and nutritional factors, all of which together make up a healthy rural population. And today it's a real struggle for whether it's a hospital or folks in practice. So I think there'll be some initiatives around how do we develop a system for rural areas that take into account some of the socioeconomic factors as well as the physical distances they have. The challenges with broadband are there. I don't know, Paul, do you have other thoughts?
No, I mean, this is where in the Trump administration, the policy was to default to the states as frequently as you can on items like this. But limiting factors were things like access to broadband or the availability of virtual telehealth and things like that. I think this is one that will default mostly to the governors, and the stimulus from the federal government and its funding will be that what we need are outpatient emergency and coordinated care around primary care, mental health, prophylactic dentistry, nutrition, and a formulary. And the attention will not be on hospitals that have fewer than 25 beds. And I think that'll kind of reshape what we think of as rural health. States like Georgia are kind of already thinking through this as the future of, quote, rural health.
Well, I appreciate that, gentlemen. We've had some great questions come in, so definitely appreciate all this engagement from our attendees. Paul, Mitch, and Eric, you've been fantastic, so thank you so much.
Thank you, gentlemen.
Thank you.
Thanks, everybody. Appreciate your joining.
And I also want to take this moment to thank Optum for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-event webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.